From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello, and welcome to this episode of JAMA Author Interview Podcasts. I'm Dr. Linda Brubaker, Deputy Editor at JAMA, and today I'm joined by two of our authors who recently published a paper called Comparison of No-Test Telehealth and In-Person Medication Abortion. I'd like to welcome Dr. Lauren Ralph, who is an Associate Professor and Epidemiologist in the Department of Obstetrics, Gynecology, and Reproductive Sciences at the University of California, San Francisco, and the Senior Author, Dr. Daniel Grossman, who is a professor and the director of the Advancing New Standards in Reproductive Health group within the Department of Obstetrics, Gynecology, and Reproductive Sciences at UCSF. Welcome to you both.
It's great to be here.
Thank you very much.
Dr. Ralph, could you start by just letting us know a little bit about why you did this study at this time?
Definitely. So we know that access to abortion is probably in a more precarious position today than perhaps at any point in recent history. The data are showing that despite the increased restrictions on abortion and bans in a number of different states, that the need for abortion is not going away, even though it's becoming increasingly difficult to access. So we are really interested in identifying models of abortion care that maintain or ensure access for those that now live perhaps hundreds of miles away from the nearest abortion facility, or for those for whom travel is a really significant barrier or perhaps even obstacle to care. So in this study, we looked at one of those models that removes the need for an in-person visit to a clinic and conducts assessment of a patient's eligibility for medication abortion using telehealth. And we examined whether if you receive a medication abortion using this model of care, whether it is as effective as going to a clinic and having an ultrasound and receiving care fully in person.
Excellent. Dr. Grossman, as a physician, can you comment on the safety of these medications and how you decided whether these models might be safe and adequate for study?
Well, there's a great deal of evidence already published about the safety of mifepristone and misoprostol for early medication abortion. In fact, I think this treatment is one of the most well-studied treatments that we have. And mifepristone has been approved by the FDA since 2000. And we have a great deal of safety evidence demonstrating that serious adverse events in general occur around 0.5% or less among patients using this treatment. So we have a great deal of safety evidence. And although our study that was just recently published was not powered specifically to look at safety outcomes, I think our findings are really quite consistent, again, with the published literature demonstrating the safety of medication abortion provided using mifepristone and misoprostol, including through all the different ways that we looked at in this study.
Dr. Ralph, how did you set the primary outcome of effectiveness? How did you determine effectiveness?
So in this study, we looked at effectiveness of medication abortion as our primary outcome, and we defined it as a patient having a complete abortion. So that means an abortion without the need for a follow-up procedure or repeating the mifepristone misoprostol regimen. So that was how we defined effectiveness in this study.
Dr. Ralph, can you briefly describe the groups that you compared?
Yes, definitely. So in this study, we recruited just under 600 pregnant people who were seeking medication abortion at facilities in 6 different states across the U.S. Study participants were divided into 3 study groups based on the model of medication abortion care that they received. And so these groups included one that was a group that received no test, telehealth eligibility assessment, and were mailed their medications. Then there was a second group that had no test eligibility assessment and picked up their medications at the facility or at the clinic. And finally, there was a third group, which was our comparison group, that received care fully in person with ultrasound.
And Dr. Grossman, what were the main findings of the study?
Well, I will let Dr. Ralph go through the details of all the various sensitivity analyses that we did. But the bottom line is that we demonstrated that in terms of effectiveness, the telehealth with mailing of the medications model to provide medication abortion was non-inferior in terms of effectiveness compared to in-person assessment with in-person dispensing of the medications. So essentially, there was really the telehealth model with mailing of the medications was just as good in terms of effectiveness as in-person assessment with in-person dispensing.
And Dr. Ralph, do you want to add any details to that?
Definitely. So one of the things that we looked at is when we looked at the sociodemographic and pregnancy characteristics of the sample by study group, so by those 3 different study groups, there were some differences by age and by race and ethnicity in our groups. But importantly, there were no differences in how far along people were in their pregnancy. So across all study groups, participants were about 47 days along in pregnancy, which is about 6.5 weeks pregnant. And that's probably the covariate that is most, or the factor that is most strongly associated with effectiveness of medication abortion. And so we were able to adjust for any differences we observed between the study groups in determining effectiveness overall and by group. But it was very reassuring that we had no differences in pregnancy duration by study group.
Can you describe the complications, even the rates that were fairly low?
Definitely. When we looked at safety in our study sample, overall, across all study groups, about 1% reported a serious adverse event. And again, we defined a serious adverse event as an overnight hospitalization, a blood transfusion, or a surgery. Now, the numbers are too small really to look at differences by group statistically, but descriptively, we found that there were 3 adverse events in the in-person with ultrasound group, so our comparison group, 3 adverse events in the no-test telehealth with mailing of medications group, and no adverse events in the no-test with medication pickup group. So very low adverse events overall. The types of adverse events that we observed in this study included 4 overnight hospitalizations, 2 blood transfusions, and 1 ectopic pregnancy, 1 surgery for an ectopic pregnancy. I wanted to just mention, though, I do think that since we rely on patient-reported outcomes for this study, I think it does mean that we have conservative findings here with respect to safety. So, for example, when we're asking patients if they spent the night in the hospital when seeking follow-up care, I think we're actually capturing those that had a really long stay in a busy emergency department, as well as those who were getting care related to the abortion.
Dr. Grossman, can you put this evidence in context for clinicians who are providing this medical care?
Yeah, I think that our study adds to a body of literature that really clearly demonstrates that mifepristone for medication abortion may be dispensed using a pharmacy, either a brick and mortar pharmacy or through a mail order pharmacy or through the clinician mailing the medication directly to a patient. And that these models of care, including when they're combined with telehealth evaluation, are safe and effective. I think this is really, by my count, the 7th study now that has been published in the US looking at models of care providing medication abortion where the mifepristone is dispensed through the mail or remotely, including after telehealth evaluation. And the results are really quite consistent. Our study, I think, certainly adds to the literature because its prospective nature, the fact that we had very low loss to follow-up in the study, the fact that we had a concurrently recruited control group who was receiving care in person, all those adding to the strengths of the study. But I think this clearly shows, first of all, that the Food and Drug Administration made the correct decision in 2021 to change the way it regulates mifepristone and eliminated the in-person dispensing requirement and allowed the provision of telehealth provision. And I think clinicians who are interested in either adding telehealth medication abortion or expanding their practice to incorporate medication abortion for the first time should feel very reassured that the service can be safely and effectively provided using telehealth and with mailing the medication or using a pharmacy to dispense it.
That's very helpful evidence. I'd like to thank you both, Dr. Ralph and Dr. Grossman, for contributing this evidence in this very important area of medical care. I am Dr. Linda Brubaker, and I've been speaking with Dr. Lauren Ralph and Dr. Daniel Grossman about medication abortion. You can find a link to their article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for the JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.